Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Sandoz.
This program is presented by Medscape Education Global.
Hello, I'm Gavin Giovannoni, Professor of Neurology at the Blizzard Institute, and I'm based in the Faculty of Medicine and Dentistry at Queen Mary University of London. Welcome to this program entitled Interpreting JC Virus Test Results in Multiple Sclerosis Management. Are you up to speed? We have a very exciting program for you today. First, I will provide an introduction about why is JC virus testing a relevant topic. Then I will discuss two cases each with my colleagues Ruth Dobson, also from Queen Mary University of London, and Orhan Aktas from the Heinrich Heine University in Düsseldorf, Germany. We'll discuss some JC virus testing scenarios with natalizumab and its biosimilar and the assays associated with each and how you use those results in clinical practice. Why is JC virus testing a relevant topic? Natalizumab, which is a very effective therapy for multiple sclerosis, blocks trafficking of white blood cells into the central nervous system. In other words, it stops immune surveillance. And by doing this, it creates an organ-specific immune privileged site. So if you get an infection within the central nervous system, the immune system can't find that virus and causes serious infection. And that's what PML is. It's a infection within the central nervous system from the JC virus. The other side of it, if you do get that infection and you remove natalizumab, you get a rebound inflammatory response to that virus, which is called iris, and that's a very serious complication of the PML that can occur in MS patients on natalizumab. Now, to get PML, you have to have the virus, so this is why the testing is important. So most people aren't aware whether they have the virus or not, because when you get exposed to the JC virus initially, in other words, the primary infection, there are no specific symptoms. And depending which country you're living, between 50 and 60% of the adult population are JC virus positive. So to get PML, you have to have the virus. Okay. The next thing is the actual level of antibody to the virus, which is what we call the index, also tells you that the virus is active or inactive in your body. So people with a very high index means the virus is active, and they had much higher risk of getting PML. Now, the virus that actually causes PML is a mutant strain, and the mutations take time to evolve. So we know, so from the time somebody seroconverts, in other words, gets exposed to the virus, to develop PML literally takes months to years, and that's why the risk of developing PML only really rises about 24 months after being exposed to the virus for the first time. So somebody who is seropositive, you have got time to make decisions about what you do with their treatment if they seroconvert, in other words, become a JC virus positive. Now, there are two products available at the moment. There may be more products in the future, and there are two different JC virus assays associated with each product. So in terms of the innovator or reference product, the original one, there's the stratifier assay, which is available when using that product. And now that we've got a new biosimilar, we've got an immunoL assay that's used with the biosimilar. The assays are pretty much the same in terms of their methodology. They use it's an immunoassay and ELISA methodology. And because they're two different assays, their sensitivities and specificities are slightly different. And it's very difficult to compare them because we don't really have a diagnostic gold standard. So we have to probably interpret them very similarly in the right context, which is why we're having the discussion around these cases. And because of these different sensitivities and specificities, the cutoff values differ between the two tests. And this is probably why it's raised certain concerns for clinicians regarding the differences in results between the two tests. I must stress, though, the reason why we get biosimilars is because the patent life usually expires on the innovative compound and the price drops for the healthcare systems that use Nadaluz. And so there has been some pressure in various healthcare systems for us to use the biosimilar, which means you as a clinician or healthcare professional looking after people with multiple sclerosis need to understand the differences between the two formulations and the assays they use. And you have to be able to interpret the results and communicate the results in terms of PML risk and the de-risking of PML with patients. And with that in mind, I would like you to click to the next chapter where I'm going to discuss some common JC virus testing scenarios with my colleague, Ruth Dobson. Hello again, I'm Gavin Giovannoni. I'm here with Ruth Dobson, Professor of Clinical Neurology and Centre Lead at the Centre of Preventive Neurology at the Wilson Institute of Population Health at Queen Mary University of London. Welcome, Ruth.
Thanks. Nice to join you.
So, Ruth, you've been involved in studies comparing the JCV test results between the two available and in a variety of clinical scenarios. I talk about the two. I'm talking about the Stratify for the reference natalizumab, the original one, and the Immunowell for the biosimilar that's just been released. I'm aware that we've published UK consensus guidelines and a statement on the testing approaches with the biosimilar. And we were discussing some of the factors I think we need to take into account when testing patients in different scenarios. So if we don't mind, let's start off with the first, and I think this is probably the commonest scenario. We have a patient who is naive to natalizumab. They haven't seen either the original reference compound or the biosimilar, and they test positive on the Immunowell, the new assay for the biosimilar. Is this going to affect your management in any way?
So, thanks, Gavin. And I think the first thing to think about is whether that affects your management in the immediate term and then whether it affects the slightly longer term management. So, for me, if somebody is suitable for natalizumab, if it's the drug that as a clinician I think is the right drug for that patient, I don't think that either a positive or a negative test really affects that when you're talking about treatment initiation. And the reason for that is actually that the risk of PML in JCV positive individuals remains really low for the first 2 years of natalizumab treatment. And so if somebody tests positive, it's not a reason not to offer them treatment. It's probably a reason to discuss the cumulative risk and the fact that you might want to switch or de-risk therapy after 12 to 24 months. And the reason that I say that is that natalizumab really has one of the lowest therapeutic lags. It's a really effective treatment. So it can be a really, really good starting treatment for people, particularly with highly active disease prior to diagnosis and treatment initiation.
Now, what about the index? Do you think the level is important, Ruth?
I think at that first point, I think at the point when you're talking about initiating treatment, I don't actually think that the index, and actually sometimes, I will start people without knowing what their JCV sera status is or what their index is, and actually get the test back a month or two into their treatment. So I don't think the index affects that initial treatment plan. I think as you go forward with treatment over time, then it may affect your treatment plan, and people with higher indexes, you may feel more strongly about switching or de-risking them earlier. But that's really an individual discussion with that patient.
Now, maybe we should discuss this now. What do you mean by this term de-risking? I mean, it's a broad term.
So, I think that when you think about the risk of PML in somebody on natalizumab who's JC virus positive, your JCV index is one factor that goes into this, but there are other factors that affect somebody's overall risk of PML. So, whether somebody's previously had immunosuppressant therapy, somebody's age, and so all of these things need to influence your discussion with that patient.
Do you think age should come into it?
I do think age should come into it. I think that we see sort of more globally immunosenescence with age, and I think age probably does impact on somebody's risk of adverse events on therapy. So I think it's a consideration, but it's not that one particular thing will totally influence everything. It's all part of that shared decision making with the patient.
And the extended interval dosing, the 6 weekly dosing that we tend to use. Are you happy that it's as effective as the 4 weekly dosing?
So I think with the 6 weekly dosing, the study that really sort of started this in use was the NOVA study that showed that overall there was no loss of disease efficacy in people with receiving 6 weekly or extended interval dosing. And subsequent work, particularly from Holland, has demonstrated that actually you can refine this even further with natalizumab levels in individual people looking at personalized dosing intervals. We do use it quite a lot. I think people have used it as a risk mitigation strategy for PML on the basis of actually quite limited data in effect, because where it's been looked at as a safety measure, there's so few cases of PML now because we're so good at risk mitigation overall in terms of switching people after a couple of years of therapy, in terms of selecting JCV negative people, that I think that data is slightly harder to interpret. But I think it brings people into hospital less. It's probably as effective. The data shows it's as effective. You're not getting breakthrough relapses. So yeah, it's something that I offer.
And now coming to using the assay in clinical practice, if somebody is seronegative and then converts on the immuno assay, are you going to use that any differently, that information is compared to the previous stratify assay?
So I think you have to take the result that's in front of you. I think when we talk about seroconversion in the assays, one thing that it's really worth bearing in mind is that none of these assays are perfect. They all use a continuous scale and actually sort of set cutoffs for positive and negative where the assay can detect things. And we also know that there's about 3 to 6% of people per year who might go from being negative on the assay to positive on the assay. So seroconversion does happen. So I think when you're looking at assay results, and particularly when people are switching between different assays, whilst it can get more complicated in terms of discussing precise risk for that patient, I think we have to take the principle that um, we've got to be safe when using the drug. You've got to take the assay result in front of you and discuss that with the patient.
Yeah, so I just also want to highlight that, negative to low positive, and if you stay low positive, that's a very different seroconversion from a negative to a high positive. The high positive is likely to be infected with the virus. I think from a risk perspective, those two scenarios are slightly different. I don't think it matters what assay you do that with. The information is the same. So, I think you have to keep that in mind, that the risk associated with the index is the high index, not the low index. And there are quite a large number of patients that bobble around the bottom, a negative one time, the next low positive, and vice versa. And I think those people are in a different risk category to the ones that convert and become high index
I mean,
positive.
I think those patients that bob around those negative, low positive, probably just about have detectable response, but it's right around the limit of detection of those assays. So I agree, those patients have got, very, very low titers of JCV index. That's very different from someone who's having a very profound and ongoing immune response to the virus.
So the key messages from these scenarios is that when using natalizumab, whether or not it's the original innovator compound or the biosimilar, the principles are the same. And when you're using the Stratify or the new Immunowell assay for the biosimilar, they're used in exactly the same way in these types of patients. In other words, if somebody is naive, you use that assay for them, make decisions around that assay, and if they seroconvert, it's very much the same information. So please now continue to the next chapter where Ruth and I will discuss another scenario. Hello again. Ruth and I are going to discuss another scenario, which is one of the more common ones. So this is a patient on natalizumab and is JC virus negative on the stratified JCV assay, and they are switched to the new biosimilar, and now they test positive on the Immunowell assay. So Ruth, how will this affect your management if they are now, let's argue, low index positive on the Immunowell assay, and we'll discuss the high index positive secondly. What factors do you take into account?
Yeah, thanks, Gavin. So this was a question really that prompted quite a lot of thought as we started to see patients who were switching between originator and biosimilar natalizumab. switching tests and suddenly noticing that a lot of patients were flipping from being negative to low positive. Um, and this was quite a common situation. So we looked at 497 patients from various centres in the UK and found that actually about half of them were later positive on the Immunowell test, having been negative on Stratify. And so it's a common problem. It's something that comes up, and I think there's two aspects to this problem. I think there's the challenge that comes in terms of how you manage somebody's risk, and then there's the challenge that comes actually in terms of how you discuss this risk with patients. Because actually, particularly for people that have been on natalizumab for some time, for a number of years, have been very happy on the drug, actually discussing risk profile can be really anxiety provoking for both clinicians and for patients. And I think that's a challenge that maybe we don't talk about enough. So in terms of actually what the approach is, so we did some consensus guidance around this in the UK, and what we did was we brought together a number of clinicians working in the MS space who'd faced this problem and tried to work out actually what is a pragmatic way forward for this. Because when patients or people living with MS have a negative JCV index on Stratify but measure as low positive on Immunowell, our feeling was probably that the biological factor being measured was stable, that actually the biological factor hadn't changed, but the assay results were telling you something slightly different. And as I talked to in the last section, this is around sort of the fact that you're using a continuous assay and putting people into discrete categories with this. So the way that, and this is not just my thoughts, but a group of clinicians thought, was actually to speak to patients and say that your absolute risk of PML has likely not changed significantly in the short term, that there may be some long-term risks. And actually this relates to the fact that we know that a proportion of patients seroconvert every year. So as we talked about in the previous scenario, around 3 to 6 people go from JCV negative to JCV positive per year and remain positive. So when you see discrepancies between the assay, you can't guarantee that that person's not in that 3 to 6%. So in terms of the recommendations, what we said was actually to reassure people that it's safe to stay on natalizumab, particularly in the shorter term for months. But over the next 12 to 24 months, really have that discussion around risk mitigation, around that person's individual risk benefit and whether they require to be switched or de-risked to a different therapy.
So I suppose if they stay low positive, that would mean that they are probably remain low risk. I suppose if, as you alluded to, if the index starts to rise and continues to rise, it means that the virus is probably active, and that should be probably.
Yeah, so I think this is it. I think I'd be a lot more worried about somebody who sort of seroconverts between assays and then their index rises and rises and rises. We know that the repeatability of both of the tests is very good. So people, actually, if the biological factor, the JCV index isn't changing, you should get the same result when you repeat the test. So actually, if that is changing on the same test, that's telling you that something's changing.
Now, but what about the high positive now? So we're going from negative on the Stratify, and now you've got a high positive on the Immunowell. Are you going to treat that differently?
Yeah, so this is the really tricky one, and this is the one that I think is particularly anxiety provoking for both patients and clinicians, because again, it does happen. It's we've seen it again in our UK data from both people who are negative and also substantial number of people who are low positive moving to being high positive. So really moving into the category that would be thought of as highest risk based purely on JCV antibody results. And again, for this population, I think one of the really important things is that there's no immediate need to switch or change therapy. That actually, when you move between risk categories, your risk doesn't change immediately; it changes over time. And it may be for these people, particularly those who move from low positive to high positive, that their absolute risk of PML over time might have changed. There is a degree of uncertainty, but I think we do need to think about treatment switching or de-risking, typically 12 to 24 months after the first positive test, assuming that their test results remain the same.
Okay, so that's so my interpretation then is somebody. I mean, this could actually happen on the Stratify assay. You can be zero negative, and then seroconvert to a high positive. So I think the interpretation is probably the same and is moving to assays. You've got to treat them as probably recently infected with the virus. gives you some time to then discuss de-risking 12 to 24 months down the line. So I don't think this changes much in terms of how we use the assays in terms of risk stratification.
No, but I think it does create a challenge when you're seeing sort of more positive results, particularly come through from people who've been established and negative for some time. And I think, this is where it sort of feeds into actually how you communicate around this as well. Because there are lots of patients actually, or people with MS who wish to remain on natalizumab despite potential risk of PML. And I think, that's also a consideration that often people have had very severe disease before starting treatment. They've had a very effective treatment and don't want to switch. So I think it's not a one size fits all answer. It's actually about that discussion.
Yeah, I agree. And there's one thing about natalizumab is that sometimes the symptomatic benefit in terms of fatigue, cognitive cog fog, what do you call it, is so dramatic that people are, prepared to live with that risk. Even if they go on to extended interval dosing, they don't want to change. And I think that's the one thing about natalizumab is this major impact on symptoms and quality of life. So people like to continue on the drug regardless of the risk. So then if we can summarize then, the discrepancy between the stratify and immunoral assays is more likely to do with the sensitivity at the lower end of the assay and should be interpreted as such. So negative to low positive is probably, from a biological perspective, should be treated the same, and then see what happens to the index over time. If you go from negative to a high positive, that's probable true seroconversion. In other words, the person's become infected with the virus. And you don't have to do anything immediately in terms of de-risking. You've got 12 to 24 months to consider what you do long term. And that doesn't necessarily mean the patient has to stop, depending on their risk aversion and why they're on the drug. You have to personalize that decision. So I'm now going to continue on to the next chapter where I'll discuss another scenario with Orhan Aktas. So we'll see you in the next chapter. Hello again, I'm Gavin Giovannoni. I'm here now with Orhan Aktas, Professor of Neurology at the Department of Neurology in Heinrich Heine University, Düsseldorf in Germany. Welcome, Orhan.
Thank you for having me here.
Yeah, so in the previous chapters, Ruth and I have been talking about recommendations and data mainly from the UK. So we're very interested in having your perspective, particularly as you live in Germany and practice in Germany, and you also have some perspective across Europe. You may have different approaches, for example, to the testing that you do in your own clinic. So I'd like to start off with a scenario. This is a patient with multiple sclerosis on natalizumab, and they are JC virus positive on the stratified JCD assay, which is linked to the innovator original compound. And when they switch to the biosimilar, the immunowell assay comes back as being negative. So I'd like to ask you, let's assume that this patient has got a low index. So this will be a low risk of PML range. How's that going to affect your management switching from a positive to a negative, Orhan?
Well, actually, this is a scenario which could theoretically happen, but which I would not expect at all, because in my experience, and also according to the data from the UK group, that immunowell assay is more sensitive. In this context, if it happens at all, then it's obviously a very, very small number of cases, and therefore, because of the higher sensitivity of the immunowell assay, I would check, of course, whether all the sample handling and management worked really correctly, but there was no mistake with the submission of the sample, and I will check that again.
Okay, but I suppose the fact that it's a low index going to a negative, it's not going to really change the risk profile of that patient substantially because you're going from a low to a negative. Would you agree with me on that? Okay.
I agree with that, because it would then, of course, confirm that that obviously the immunoreactivity towards the virus is quite low. And of course, in the context also of the specific issues of the test, they do not measure, of course, one-on-one really the same biological thing, but at least a similar process. And therefore, we have to understand that in order to evaluate these results in a proper manner, also always in the clinical context.
So now let's go to the other variant, let's say they were high positive, so they were high risk of PML on the Stratify assay, so on the innovator natalizumab formulation, and now they become negative. I suppose that's going to be even a rarer scenario. And how are you going to deal with that in clinic?
Yeah, indeed. Again, checking that and trying to understand whether something was really in this context was correct, because the probability that a high stratify index to a low immunovel status, this is quite low.
I also want to point out, just even before we had the biosimilar, before we even had the immunowell assay, just using the stratified JCV assay, we had that scenario anyway. We had people going from positives, and some of them were relatively high index, to becoming negative as well. So I think, even within the same assay, that could happen. You could switch from a positive to a negative, and I would assume you'd have to treat the information the same way as you would do if you're switching assays.
I agree. Of course, as we have that with all kind of biological measurements, we have to think about also natural fluctuations, and there may be other factors that we are not aware of, which also influence, of course, the test results. What's important now is that whenever we have kind of a change in these results, um, I think the first thing is that we should keep calm, don't panic with regards to kind of assay changes. I advise not to change the whole therapy just based on a single test result, but rather to see the, the whole patient and also the treatment scenario. If it really turns out to be true that, for example, certain change really is detectable in a persisting manner, then of course to discuss those therapeutic options.
So I suppose what we both discussing here is that we would take the precautionary approach. We would treat the positive on the previous assay or the previous test as being significant. We wouldn't ignore that positive, and we would probably treat that patient as being at risk of complications due to PML, and wouldn't ignore the positive results. I think that's the message we need to get across. We wouldn't ignore the positive result if a future assay became negative. Would you agree with me on that?
Yeah, this thing. I think really the same approach that we have both in UK but also in continental Europe, in Germany. Yeah, and we think that the positive assay, let's say, beats the negative assay. It's whenever we have a positive assay, we should take care of that. We shouldn't panic, but nevertheless, of course, take that serious. And of course, in this context, also take into account the background of a given patient's history, and that means also trying to specify the individual risk. And we know that from the old data that, for example, the duration of treatment with natalizumab or the biosimilar probably, but also, of course, the pre-treatments like previous immunosuppression and also age of the given patient, also have on the individual risk of getting a PML. And these are all factors that we should consider when we then, of course, evaluate and also discuss these issues, both with the patient, but also, of course, with the patient's relatives, and in order to go along the shared decision making process.
Okay, so for me to summarize then from the scenario of a positive to negative switch when you change assays and formulations, I think the default position is always to apply the precautionary principle and not ignore the previous positive assay, and then obviously take other things into account: the index, how high it is, disease duration, patient factors like disease activity, approach to risk before making a decision. And I suppose that if you are going to then put this patient in a high risk category, you'd obviously have to de-risk with extended interval dosing, and possibly in the future discuss switching. So I would like you to continue on now to the next chapter, where Orhan and I will discuss another interesting scenario relevant to your clinical practice. Hello again. I'm here with Orhan Aktas to discuss another JCV testing scenario. So this is a patient on natalizumab and is JC virus negative on the Stratify assay, who then switches to the biosimilar natalizumab and tests negative on the immunowell assay. This is all fine, so they're negative, negative. But this patient now subsequently seroconverts to becoming low index JCV seropositive on the immunoassay. So this will be with a 6 monthly testing. So, Owen, how will that affect your management as the seroconversion is to a low index positive on the immunowell?
Well, I think that we need here a holistic approach, holistic in terms of that we take into account, of course, this positive results. Even if it's low positive, this is kind of a signal that we should take serious. But on the other hand, also to to put that in context of the given patient, given in context of his previous treatments, previous specific risk factors regarding the development of PML. Also, is clinical status, clinical stability, for example, MRI investigations in the past, and trying to understand also the patient attitudes. Because based on the treatment duration, a low positive index doesn't mean that we necessarily have to switch now to a medication or stop medication. And in any case, such a switch and a change of a medication should always also be prepared. We know that stopping natalizumab means that we already have an alternative inside in order to prevent a kind of a rebound. And one approach would be, of course, taking the patient's specific clinical situation into account. Um, Repeating the assay, taking into account the duration, because we know up to 24 months this will be not an issue. And but at the end, of course, if we really see, and that's now the specific issue for on longitudinal measurement, a kind of a dynamic, then of course, clearly this would be a signal to react.
So if this patient, say, had the repeat 6 and then 12-month assay after starting the biosimilar and the index is going up, would that affect your decision making?
Yes, indeed. Of course, such a dynamic, this is something that I just mentioned, indicates that obviously the virus is much more prominent and present to the immune system, that the immune system takes care of the virus. This now something not totally unexpected. We know that from the longitudinal data from German and French studies that this happens. Particularly if the in the index, of course, reaches the known thresholds, then we have to really think about adapting the therapy and applying de-risking strategies.
So obviously this is a lesson about why we need, as you mentioned, trajectories, longitudinal assessments before making knee-jerk decisions. And it also means preparing the patient, I suppose. You can prepare them for the possibility of either de-risking the drug by going on to extended interval dosing and having frequent MRI monitoring for PML, or the switch that you've already mentioned. Now, what I want to explore with you, Juan, is in Germany, there has been some studies showing you that the risk of PML is taken much more seriously by clinicians than patients. They seem to deal with the risk better than clinicians. Is that still the playing field in Germany, or have patients and clinicians caught up with each other?
Well, it really depends on the given treatment scenario, whether it's a center which is used, of course, to also management also of the testing, or how well experienced and also how accessible also additional means of investigation of the patients are in terms of, for example, how easy we can do also MRI measurements and even, of course, also offer the patient, given his or her, let's say, individual risk attitude, a lumbar puncture for detecting JC virus. At least we try to adapt now the UK perspective in terms of that we really try to inform the patient as much as possible, to include the patient to our decisions, rather leaving the paternalistic or maternalistic perspective than just deciding for the patient, but rather deciding with the patient, and always having in mind also that we need the alternative when we discuss these kind of findings. We have to discuss with the patient a perspective, an alternative. Otherwise, in order not to leave the patient alone with such a finding. But this is, of course, an issue of time. I really always advise that it's worth discussing that with the patient and also with the patient's relatives, so that really also the environment of the patient also understand that. It's not easy.
Yes, I think listening to you, it's quite clear that we aligned. I think we aligned across Europe, to be honest with you, and probably the world, in that we've seen a massive drop in the incidence of PML by applying the risk stratification algorithms. And I think nothing changes when you switch from stratify JCV to the immuno. The cutoffs may be different because of a different assay, but the principles are the same. And I would imagine that nothing will change in the way we manage people with MS that seroconvert or positive with a high index. We will inform them about the risks and de-risk them as they feel appropriate. However, we've always got a small group of patients that refuse to move because they're doing so well on natalizumab. And I think those patients need to be made aware that we'll do our best to monitor them and try and pick up PML if it does occur in the asymptomatic phase, so we give them the best chance of recovering.
I totally agree with that because it's really quite interesting to see the benefit of natalizumab when the patient had another trial, other medication before. Really, I have many patients who, even though they have a zero conversion and then switch to low positive, they really prefer staying on natalizumab in spite of discussion of the possible risks. And therefore, as you just suggested, a close supervision of the patient helps to keep them safe.
Okay, then to summarize, then the key messages from this scenario is I think both assays provide immunological information. In other words, an antibody titer or index. In other words, the immune system has memory of seeing the virus. I think a low index, however, must always be interpreted as possibly in a false positive, particularly people bouncing along the bottom of the sensitivity of the assay. So that doesn't always mean switching therapies. You need to just look at trajectories then. A high index or a rising titer implies true seroconversion, and it's telling you that the virus is probably active, sending up antibody titers. And I think it's really important at this stage to tell the patient about the higher risks associated with a high index or rising index. And at this stage, it may be worth considering de-risking or switching treatments, depending on the patient's attitude. And I think, overall, as neurologists, I think it's best to apply the cautionary principle and accept a positive result from either assay. And I think once somebody is positive, you can't ignore that, and you have to treat that particular individual as always being positive, and then obviously make decisions around the risk of PML based on the trajectory of the index and all the other factors that we've discussed in terms of PML risk stratification. So I think if I have to conclude overall, PML remains a legitimate concern in people on natalizumab or its biosimilar. And I think the declining number of cases we're seeing globally is a real testament to how the MS community and the pharmaceutical industry has helped us put in place risk profiling and how we've learned how to de-risk natalizumab treatment in terms of PML. So there are lots of advantages of having natalizumab available to us. But at the same time, we've got many more treatment options that will allow us to de-risk people on natalizumab if we're worried about the PML risk. So I think having a biosimilar helps the healthcare system, and having a new assay to help with risking is a good thing. The fact that the biosimilar has been approved by regulatory authorities with the assay means that we as a community are going to have to get used to using the new product with its associated assay. I think the principles underlying monitoring for PML risk are identical whichever formulation the patients are on, and we have to use both assays in a very similar way. Now, obviously, what we've discussed in these scenarios are when the results aren't aligned with each other. But I think if you use common sense and the precautionary principles, we shouldn't be putting our patients at any higher risk of PML on the new formulation if we use the assay in the same way as we used them in the past, and we apply the precautionary principle: once positive, always positive. Hopefully, with the new formulation, we'll be able to gather long-term data and learn from patients on the biosimilar. I can't see any reason why the PML risk will be any different, because the immunological underpinnings of why people develop PML don't change whether or not you're on the innovator compound or the biosimilar. So I would like to thank you, Orhan and Ruth, as well for these great discussions. And
I'd also like to thank you, the audience, for participating in this activity. Please continue on to now answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.